All right, so heart failure. So heart failure can have multiple etiologies. The two that seem to be the most prevalent are some form of ischemic heart disease, coronary heart disease, and hypertension. But heart failure comes from multiple different types of etiologies. Generally, the pathogenesis with heart failure involves the heart having some sort of problem with either contracting or relaxing, or for individuals who are really unlucky, having an impairment with both. This leads to the heart being unable to provide enough output to meet the demands of either tissues or organs, or the heart itself, and can lead to systemic or pulmonary venous circulation congestion, being like pedal edema or pulmonary edema, backflow of some form, and inadequate cardiac output on the front end. So heart failure itself can be divided up into either what are considered sort of older terms, systolic dysfunction or diastolic dysfunction. With systolic dysfunction, this is more often nowadays called heart failure with reduced ejection fraction because of the fact that the ejection fraction is now reduced. And for those who don't remember, ejection fraction, this right here is the square, is the volume of blood that the atrias pump into the ventricles. This is the total amount pumped in at the end of diastole. This right here is the amount that's pumped out of the ventricle during systole. And so the ejection fraction is the amount of blood that's pumped out of the ventricle compared to what it was holding at the end of diastole. So when it comes to heart failure with reduced ejection fraction, the most common etiology here is going to be a heart attack or myocardial infarction. And the main problem with heart failure with reduced ejection fraction is that we have a decrease in contractility. The problem is that the heart has experienced muscle cell death. And so with that muscle cell death, we have an inability for those fibers to contract. And so without contraction, we're going to have a lot more blood remaining within the ventricle compared to a normal heart after systole. Okay, so we have decreased ejection fraction leading to a decreased cardiac output. So that's systolic dysfunction. Diastolic dysfunction, the main problem here is that the ventricles do not relax. So, and the etiology, for example, here would be coronary heart disease and hypertension. So this is more of like a long-term insult to the heart. We have coronary heart disease where we have inadequate blood flow to the heart over time and hypertension. Both of these are going to put a tremendous strain on the heart over a long time period, may even cause some inflammation. And throughout that process, the heart is going to end up having remodeling in the form of developing fibrous tissue. That fibrous tissue is going to restrict how well the ventricle can expand, which means that it's not going to be able to fill up as full as a normal healthy heart can. So in this case, we're going to have a normal ejection fraction because while the heart can not really fully expand and relax and accommodate the same volume of blood that you would normally have in a healthy heart, whatever amount it does have filled into it can be ejected normally. So while we have a reduced cardiac output, we will have a normal ejection fraction. It's important to remember that with this is the form of heart failure that is more likely to occur in women, elderly, and those without without a history of MI. So this diagram here is pretty good about showing the difference between systolic dysfunction and diastolic dysfunction during diastole versus systole. So with systolic dysfunction, you see the thinning here around the heart in the ventricles. This is because of the fact that we have dying tissue from most commonly an MI. So this is all weakened tissue. This all has the ability here, as you can see, of being able to fully expand to accommodate as much blood as the atria can fill up the ventricles, and compared to a normal heart. In fact, it may even be able, compared to a normal heart, may be able to fill up with more blood because there's some dilation going on. But down here, you can see during the pumping, compared to a normal heart, it's not able to fully contract. That's because there's so much less muscle tissue compared to what we have in a normal heart over here. With diastolic dysfunction, we have all of this thick muscle that's developed. It's hypertrophied over time because of the demands on the heart, like, for example, with heart failure, or hypertension. So during diastole, these are all stiff and rigid, potentially fibrotic, and so it won't be able to open up very far, especially not compared to a normal heart or systolic dysfunction. So it opens up as much as it can, but then during systole, whatever amount of blood was able to get in here is fully able to be pumped out as much as you could expect in proportion to a normal heart. The problem is you're getting a lot less volume overall compared to a normal heart. So when it comes to compensation and remodeling, this is something that the heart's going to do naturally as a means by which to try to maintain homeostasis despite having heart failure. The problem is that overall, the compensation methods that the heart tries to utilize will end up being very detrimental to the overall long-term health of the heart. So what the heart's going to try to do in order to restore cardiac output towards, homeostatic normal baseline, first we're going to try to activate SNS, which is a sympathetic nervous system. That's going to try to upregulate the heart rate. We're going to try to get the heart rate up to a higher rate, just because that way we can pump out more blood per minute. We can't necessarily increase how much we have per beat, but we can increase how many beats there are per minute by increasing the rate. We can also activate RAS, which will, in the end, activate vasoconstriction and activate fluid retention by way of aldosterone conserving sodium and thus water. That will increase the overall volume of blood that we have in the system. The problem with that is both of these mechanisms will lead to chronic increases in preload, which will lead to myocardial hypertrophy. With myocardial hypertrophy, what we have is an increased oxygen demand of the heart. And it's sort of this vicious cycle that continues on and on and on until the heart eventually just gives out. So here we can see that with heart failure, we have decreased cardiac output, and overall we're going to have a decreased pressure. So this is going to activate our baroreceptors in our brain to stimulate SNS, or go to the brain, I'm not sure what exactly this is trying to say, and activate a signal of SNS activation. Hey, SNS, wake up, we got to increase heart rate, increase contractility. RAS is going to be activated with the decrease in glomerular filtration rate. We're going to go through the entire RAS system, leading to fluid retention and sodium retention, which will increase preload. We will also have an increase in ventricular wall tension, which is preload, and that comes from the RAS and the SNS activation. that increase in preload will lead to myocyte growth, which is hypertrophy, which is just growing of the muscle in the walls of the heart. And that will lead to some fibrosis as well as an increased and even greater demand of oxygen by the heart itself, which will all of that together lead to an increase in cardiac output in the short run, but in the long run will lead to progressively more deterioration of the heart itself. So heart failure can also be classified based on whether it is left or right heart failure. Left heart failure, and determining what sort of signs and symptoms are associated with which is mostly dependent upon what area of the body just came from or is serving to that portion of the heart. So, for example, we know that blood that is in the left ventricle just came from the lungs. Blood that's in the right ventricle just came from the body. So knowing that, we can kind of deduce that, I think it's deduce, is it induce or deduce? I don't know. We can conclude that if the blood in the left ventricle is not able to be ejected, which is the way it works with heart failure, then all of that blood is going to end up getting backed up to wherever it came from, which with left-sided heart failure would end up going back to the lungs. So as you can see here, left-sided heart failure, we have decreased cardiac output, but we end up having pulmonary congestion as our primary backwards effect of heart failure. So we're going to have potentially pulmonary edema, impaired gas exchange. That pulmonary edema can result in a cough with frothy sputum, orthopnea, paroxysmal nocturnal dyspnea, which is that inability or that difficulty in breathing during night when you're lying flat, because all that fluid that normally when you're standing or sitting would accumulate in the bases of your lungs suddenly gets spread out amongst multiple lobes along, as you stand along the vertical length of your lungs because you're lying flat. A lot of patients have actually reported that they feel as if they are actively drowning. The impaired gas exchange in the lungs because of the pulmonary congestion can lead to then cyanosis and signs of hypoxia. With both, you're going to see a decrease cardiac output, maybe not directly as much so with right-sided heart failure since it's going to the lungs and then to the left ventricle. But we're going to have decreased cardiac output regardless, which is going to show a lot of the same kinds of signs and symptoms, such as decreased oxygen perfusion and decreased blood flow to the tissues. So we're going to have a classic signs and symptoms of activity intolerance and signs of just generally decreased tissue perfusion. Right-sided heart failure, the blood to the right ventricle comes from the body. So because of that, the primary signs and symptoms that we're going to see associated with right-sided heart failure, the backwards signs and symptoms, or backwards effects, are going to be those ones about fluid accumulation behind the right ventricle. So with this, we're going to see peripheral tissues becoming congested, liver congestion, spleen congestion, dependent edema and ascites, dependent edema being down in the lower legs typically. We can see congestion in the GI tract, which can lead to anorexia because with all that extra weight and swelling and pressure in the abdomen, people are not going to feel the urge to, or the same hunger sensation, because the stomach's going to end up becoming compressed. That may lead then to weight loss, and that extra fluid may also cause GI distress. So for left-sided heart failure, the most common etiologies are going to be coronary heart disease and any form of cardiac damaging disorder. Again, the backwards effects, we're going to have increase in left atrial pressure, congestion in the pulmonary system because we're coming backwards from the left ventricle. Backwards would be the right ventricle or the left atria. Backwards from that would be then the pulmonary circuit. Forwards effects, we're going to be talking the same regarding both left-sided and right-sided. So decreased cardiac output, which means a decrease in peripheral oxygenation. The tissues are not going to have enough oxygen for general metabolism, leading to a host of issues. And typically, left-sided ventricular failure can lead to right ventricular failure. And when it comes to the forward and backward effects of, forward and backwards effects of heart failure, a lot of that can be better understood by being able to remember the circuit that the circulatory system goes through and where pressures should normally be. So we have the heart right here. The highest pressure we're going to experience comes directly out of the left ventricle, out the aorta, down to the body, the systemic tissues, because that's where we're going to have the greatest amount or the highest resistance. We're going to have so many capillaries, so many miles of vasculature that we have to be able to pump blood through to reach all areas of the body. So that's where we need the highest pressure. And similarly, because we have so many miles of tubing that we have to go through to reach back to the heart from these capillaries, and because most of this vasculature on the venous side of the systemic circulation relies on muscles and valves to push the blood back to the heart, that's why we're going to have that as our lowest pressure system. The next highest pressure system is going to be the other ventricle, the right ventricle, which leads then to our lungs. And you can remember that this is going to be a lower pressure than the systemic circuit because the pulmonary circuit only has this tiny little circuit to have to travel through. There's not much there to need to navigate compared to what you have to have coming out of the aorta and going throughout the entire body. And then the next lowest is going to be this circuit that comes from the lungs back to the heart, again, because it's lower than what you're going to have straight out of the ventricle, but it's not going to be so far gone from that and having to encounter so much resistance just from the miles of tubing. So it's not quite as a low pressure system as the venous systemic circuit. So again, going over some of the backwards and forwards effects here, pretty typical from, or the same kind of symptoms as what we had mentioned before. The other kind of systemic issues that we might experience with left-sided heart failure, we can have confusion, tachycardia, exertional dyspnea. This is a big one because patients who have heart failure, one of the biggest issues they have is exercise intolerance. And exercise is one of the best things that we can promote in our patients with heart failure, just because of the massive benefits that they can have on the heart, preventing it from remodeling and from allowing it to get stronger in the right ways. Cyanosis, fatigue, a lot of these come from simply the lack of oxygen supply and tissue perfusion that comes from low cardiac output. Pulmonary congestion can result in cough, crackles, wheezes, blood-tinged sputum, and tachypnea. We can also have oliguria because the body's like, hey, we have this massive amount of fluid, we need to get rid of it. And again, left-sided heart failure is the most common cause of right-sided heart failure. But that doesn't mean that we don't have other ways in which we can develop right-sided heart failure. So with right-sided heart failure, another option is what's called cor pulmonale. Cor pulmonale is the development of right-sided heart failure as a response to pulmonary disease. So for example, COPD, emphysema, chronic bronchitis, cystic fibrosis. There are a number of diseases, pulmonary diseases that can lead to increased pulmonary pressure or an inability, increased, just in general, blood pressure, pulmonary pressure within the lungs. All of that will lead to the right ventricle having a more difficult time pumping blood through that congested heart or congested lungs, which, in order to overcome that, will have to hypertrophy. If it has to experience that much stress constantly for that long a time period, eventually the heart can experience or develop right-sided heart failure. So in the congestion, for the backwards effects, are going to be congestion into the systemic venous system. So we're going to experience pedal edema, ascites, hepatosplenomegaly, the enlarging of the spleen and liver, and did I say ascites? I may have. Anorexia, JVD. The forwards effects are going to also, similar to left-sided heart failure, result from the low output from the left ventricle, well, to the left ventricle, and thus the left ventricle having low volumes itself. So again, a lot of it has to do with a lack of perfusion to the systemic circulation. Okay, kind of already covered that. So this right here, you can see this is a really extreme case of JVD. A lot of people can see sort of some JVD when people are in a stressed situation, but that's not real JVD. This is JVD when you're resting, which is scary. Making sure we have nothing else here. Weight gain, dependent edema, hepatosplenomegaly. Good. Okay. So overall, the treatment goals are to improve cardiac output, minimize the congestive symptoms, which overall will minimize cardiac workload, and we want to focus on minimizing cardiac workload itself as well. We do this all by manipulating preload, afterload, and contractility. Remember that preload is the volume of fluid of blood that the ventricles accept during diastole and before systole. Afterload is the amount of pressure that the ventricles have to overcome, especially the left ventricle has to overcome in order to contract the blood out of the ventricles. The amount of force that it has to overcome from the systemic vascular resistance. And then contractility is simply the amount of the forcefulness of the contraction from the heart. All right, causes of heart failure. So coronary heart disease is or ischemic heart disease as well, is a very common cause of heart failure. All of these right here are some of the risk factors for CHD. You might look at that for a moment and think, oh, okay, I understand all those, and I remember all those. Make sure you remember homocysteine, because that's not one that most people think about. I can't tell you exactly how it works because I tried looking into it and either they don't understand or it went straight over my head because I'm only going to be a nurse at this point and I'm only a nursing student, so that's okay. The increase in homocysteine, though, just remember that that does increase the risk of developing coronary heart disease. Increased homocysteine, increased coronary heart disease. The problem with coronary heart disease is that we end up having a blockage of some form in one of the vessels of the heart. That leads to a decreased level of oxygenation to the heart itself because these coronary vessels are supplying oxygen to the heart. So this can result in angina, MI, heart failure, dysrhythmias, or sudden cardiac death. So the general etiology is that we have atherosclerosis, which is some form of a buildup normally of like lipids, for example, from inflammation in the heart or in the blood vessels, narrows the arterial lumens and leads to cardiac ischemia. And this can occur through thrombus formation, which is the thrombus, remember, is the one that develops in a spot, whereas the emboli is the one that develops, breaks off, and travels downstream somewhere to occlude somewhere down there. The emboli travels, the thrombus doesn't. We can also have coronary vasospasm leading to coronary heart disease because a vasomine artery can't produce a flow of blood. If you were to take a hose and try to garden your or water your garden with it, and then you went and shook the middle of the hose really rapidly, you wouldn't be able to have as much water coming out of the hose at the very end. I'm not sure that makes that much sense to everyone, but hopefully it does. And then we also have endothelial cell dysfunction. And endothelial cells can have dysfunction from the perspective that they actually produce chemicals that interact with the clotting sequence, clotting formation, as well as vasoconstriction, vasodilation. And so dysfunction of endothelial cells can result in some form of atherosclerosis or narrowing of the lumens to begin with. And ischemia itself is the period or the state of where we have too little O2 supplied to a level of tissue to meet the metabolic demands. So when it comes to the pathophysiology of ischemia, ischemia can kind of come in two different forms, either chronic occlusions, or acute occlusions. Chronic occlusions are going to be those stable atherosclerotic plaques, which come from a slow progression and lead to stable angina pectoris, or ischemic cardiomyopathy. Acute occlusion comes from some form of a plaque disruption, which leads to a thrombus formation, I guess realistically more often a emboli disruption or formation, leading to unstable angina or MI. This will make sense on the next page. So here we have a normal lumen. Here's a lumen. This is the wall, outside wall of a artery. This is a normal, healthy artery. This one is the artery and the lumen of an artery that has had multiple bouts of inflammation, and we have currently the adaptive process going on. So this right here is a lipid pool that's got macrophages and lymphocytes, amongst other things in there, as well as this fibrin cap or fibrous cap that is developing around it to try to protect the lumen from all of this material. The fibrous cap is also to try to hold all of this together to prevent it from flowing off somewhere. It's considered a vulnerable plaque because this fibrous cap that we have here is relatively thin. So all of this stuff, if this were to break, would easily make its way into the vasculature and lead somewhere downstream to create an occlusion. This is considered a stable plaque because while we have this really tiny lumen, we also have this lipid pool covered with a very thick amount of fibrous material. So this doesn't really have much of a risk of going to the side of the lumen and forming an emboli. Unfortunately, this leads to, as we saw up here, this stable plaque leads to a chronic occlusion because of how narrow this lumen is. This vulnerable plaque has plenty of space for blood flow, But because of this weak wall with this massive lipid pool, this can easily burst and form an acute occlusion, leading to unstable angina or an MI. And another term for you guys is angina pectoris, which is simply chest pain. And the chest pain comes from some form of intermittent ischemia of the heart. It can come from, or it can present as burning sensations, crushing, squeezing, choking, or referred pain down the arm to the jaw, to the back. There's not really a limit to different ways in which it can be referred pain. Angina pectoris can also come from inefficient cardiac pumping, and leading to pulmonary congestion and shortness of breath. Normally, with regular angina, there's no permanent myocardial damage that occurs, but there's kind of a bit of an exception there. So generally, there are three kinds of anginas. We've got chronic stable angina, variant angina, or otherwise known as Prinzmetal, and unstable angina. So chronic stable angina is the kind of angina that happens when you just simply have a, where is it? It's a stable plaque that forms a chronic occlusion. So that stable plaque, stenotic atherosclerotic vessels, over time they build up and they make it difficult for enough blood to get pumped through the blood vessels. So in times, say, where we have increased activity, or perhaps times where we're cold and blood vessels have shrunken a little bit, or vasoconstricted, that is. We'll stick with activity, it makes it easier to understand. So the heart, during activity, starts to have an increased heart rate, increasing how much energy it requires and oxygen for its work. So, but we only have, according to this diagram, so much blood that we can pump through those stable plaqued arteries. So what happens? The heart starts to experience kind of cramping in a lot of ways, because we're not having at this point permanent myocardial damage. We're not having tissue death necessarily. So the activity stresses the heart. The heart can't get enough oxygen to meet this new stress, but if the person were to rest and use some nitroglycerin, that pain would be relieved. Variant angina, and also the pain onset for chronic stable angina tends to be pretty predictable. You kind of tend to know what your limits are and what kinds of lifestyle factors or situations tend to promote the sense of angina. With variant angina, this is a matter of a coronary artery spasm, and the spasm doesn't have a precipitating event. For whatever reason, a coronary artery in the heart has become hyperactive. So whether the person's at rest or they are doing some sort of activity, they'll have an unpredictable attack of pain, of angina, that they won't be able to recover from with rest. What will help them is taking a calcium channel blocker or maybe nitroglycerin. The calcium channel blocker helps to sort of calm those calcium channels and reduce how much flow is able to go through them in the level of the heart, making those blood vessels calm down. Then we have unstable angina, which falls also under the acute coronary syndrome umbrella. And acute coronary syndrome is any condition that causes sudden decreases in cardiac blood flow. So for unstable angina, this is a very serious issue, and it's caused by the vulnerable plaque. It's not the stable plaque that causes unstable angina. It is a vulnerable plaque. So that vulnerable plaque, the fibrous cap breaks, this whole lipid pool, lymphocytes, macrophages, burst out into the blood vessel, into the lumen, and find their way downstream till they block something. So with that unstable angina, eventually it could lead to a myocardial infarction. So with acute coronary syndrome, which we start with unstable angina, we have that plaque rupture, which leads to a thrombus development and can lead to unstable angina, which is a partial occlusion, or a myocardial infarction, which is a complete occlusion. We can also experience sudden cardiac arrest or death, which we'll cover and explain exactly what that is in a little bit. So with acute coronary syndrome, this is going to be chest pain plus acute ischemia that you can potentially see on an EKG. If you can see it on an EKG, that means it is ST segment elevation or a STEMI form of an MI, ST elevated myocardial infarction. What we have here is a normal EKG right here. We got the P wave, QRS wave, and a T wave. So this is the S wave, this is the T wave. This right here should normally be at baseline, as in like the normal flat segment that runs, for example, if a person were at asystole, they had no cardiac movement whatsoever. That would be their baseline. So that should be at baseline. Here is an example of when we have ST elevation. And this is an example of when we have ST depression. Two different kinds of damage, but that comes in acute too. So we can also have this candidate, or this person who has chest pain plus acute ischemia that you can see on the EKG is then a candidate for acute reperfusion therapy. But if they only have chest pain with no ST elevation, then they're only a candidate for antiplatelet drugs. Now, to give you a better example of what an a STEMI looks like compared to an N-STEMI, we have here a transverse section of the heart. So this is inside the heart. We'll call this the ventricle right here in the middle. On this side, this is the N-STEMI side, and on this side we have the STEMI side. On the N-STEMI side, the reason why there is no ST segment elevation with an N-STEMI is because we only have partial thickness of the wall depth. This right here, this section is dead cells. These are cells that have died because of a lack of oxygen. There's ischemic, there's no blood flow, ischemia to this section. So they're still on this border of the wall. There's still healthy wall segments to work with. That's why it's not a ST elevated MI. It's only a non-ST elevated MI. On this side, this is going to be a STEMI because, as you can see here, this whole section of cardiac tissue is just dead. This is full thickness death, or at least full thickness damage. Full thickness death of cardiac tissue here. And so that's going to show on an EKG as ST elevation. Now, a lot of people have struggled with sort of remembering and understanding how all of these parts play together, so I'm going to go ahead and do this. So there are three forms of angina. There is chronic stable, we'll do that instead. We have variant, and we have unstable. My V looks like a U, but I trust you all will understand how to tell the difference. So chronic stable, that was a stable plaque. Variant was vasospasm. unstable was a unstable, oh no, I'm sorry, a vulnerable plaque. So those are angina, the three forms of angina. In addition to that, we also have, I'll just move this up here for now, acute coronary syndrome. Now with acute coronary syndrome, we also have unstable angina moves down here. So unstable angina. So unstable angina is kind of part of two different groups. In addition to that, we also have NSTEMI. My handwriting is awful with this pen. And irregular STEMI. So the difference here, going back to here, an unstable angina is a partial occlusion. Whereas in both forms of MI, there is a complete occlusion. Did I spell that right? I did. Complete occlusion, complete occlusion. Additionally, for NSTEMI and STEMI, the way we differentiate is that the NSTEMI is only partial thickness damage or death, whereas the STEMI is full thickness death or damage. So that's the difference between, or sort of the way that I remembered angina versus ACS and saw how they all played in together. I'm just going to make sure real quick that I didn't miss anything regarding that. I don't think I did. Oh, and for NSTEMI, I believe it was, we have biomarkers. I'm not sure how I'm going to write that. I'm just going to say it. So NSTEMI, we have biomarkers. NSTEMI, we have both NSTEMI and STEMI have biomarkers to show that there has been damage. Unstable angina does not. Okay, so in the first one day with acute coronary syndrome, we're going to have some form of the heart, some part of the heart that is infarcted, and it's going to start to look pale. Within 1 week, that pale section is going to turn yellowish, soft, and develop a rim of red vascular connective tissue. This is the beginning of the sort of inflammatory process and protective mechanism that the heart goes through. So that's after 1 week. So 1 day, 1 week, 2 weeks, necrotic tissue is cleared, the infarct is weak, and is at a high risk of rupturing. So if a person goes through a tremendous amount of stress, putting their heart through a lot of work, they may rupture that weak infarct. At 6 weeks, we have a fibrous scar tissue that protects the heart from rupture, but as we saw earlier, can form the beginning stages of systolic dysfunction heart failure, or heart failure with reduced ejection fraction. Alrighty, so with acute coronary syndromes, we have some pretty typical manifestations. A lot of people complain of severe crushing chest pain as if they have an elephant sitting on their chest. Some people even say that they feel they have a hot knife being stabbed into their heart. That pain may also radiate to the arm, to the shoulder, to the jaw, or the back. A lot of times they experience nausea and vomiting, diaphoresis, they have just a tremendous amount of sweating going on, and shortness of breath because the heart's telling the body, hey, I'm not getting enough oxygen, up the respiratory rate. For acute coronary syndrome, it's vital to remember that they will not have their pain relieved by rest or by nitro. That doesn't mean they won't, and by relieved, we mean like a cessation, a complete stopping of the pain. We can have some form of relief, short-term relief, by nitro. We can have a patient who's given like a nitro drip or continuous nitro tabs and have them experience sort of short-term relief with that nitro. And if it's a STEMI, well, all right, backtrack. But at the same time, they will not have, if it's a full-on myocardial infarction or unstable angina, they will not be able to have complete cessation of the chest pain even with abundant nitros. If it's a STEMI, we'll also have the EKG changes, and we'll see with either a STEMI or an NSTEMI an increase in serum marker proteins. I don't believe that you can see serum marker protein increases with unstable angina. I believe that was said in the PharM lecture. Myocardial infarctions can also come with atypical clinical manifestations, such as being a silent MI, which can present with women, the elderly, or patients with diabetic neuropathy. Instead, they can experience just simple fatigue, nausea, back pain, abdominal discomfort. They may even have issues with having their MI showing on an EKG. Some people have said that they felt their little finger feeling weird, and that they felt it going up through into their tooth. MIs can have some very strange presentations, which means we always got to be on guard about whether or not we suspect an MI with a current patient. For serum markers, we got to make sure that we do a full panel, but the most important one that we look for is troponin. Troponin is going to be the one that it has the most sensitivity and the most specificity for an MI. Other ones can be helpful towards checking to see whether there's any indication of an MI, but troponins are main person. Unfortunately, troponin, as we can see here, only goes up in the first few hours and doesn't really peak until 1 to 2 days after an MI started. That means we need to be considering the idea of checking beyond when a patient first comes in with an MI, because it may take a while for it to accumulate to the point where they can actually be read in a lab. So we may have to take the lab panels 2, maybe 3 times before we rule out the option of an MI. So with a myocardial infarction, there's a decrease in cardiac output, which then leads to compensatory mechanisms. This is going to increase, detrimentally, the myocardial workload, and it'll increase by increasing heart rate, contractility, and blood pressure. With a myocardial infarction, there are a number of things that can give you or a person a poor prognosis. So a person who's saying, hey, it's not a heart attack, I'm fine, I just have indigestion. They wait too long, they have a delay in treatment, they didn't go as soon as possible to the ER. Suddenly now they have much greater extent of permanent damage than would have had if they had gone into the ER right away when they first started experiencing symptoms. If they have a clot somewhere that is more proximal, more upstream in the blood vessels, then that may block a much greater extent of the heart and damage even more heart tissue compared to if we were to have a really tiny clot that developed far downstream and only affected a tiny little portion of the heart. People with previous cardiovascular health concerns are also clearly going to have a more difficult time recovering from an MI, as well as those who have any other form of disease processes that can impact their ability to recover. And the older you are, the more difficult it is to recover from something as devastating as an MI. The treatment for an MI, our focus is to decrease the myocardial oxygen demand by decreasing preload, decreasing afterload, decreasing heart rate, decreasing blood pressure, and increase myocardial oxygen supply by finding a way to bust that clot, as well as provide enough cardiac output to supply oxygen to all the tissues, especially the heart, that we need to. We're going to monitor and manage the complications. For example, early detection is critical. That person who waits thinking that it's indigestion, they're going to have far worse outcomes than someone who decides to come into the ER right away. We're going to want to worry about dysrhythmia management because a person who's experienced a myocardial infarction is at a very high risk of developing a dysrhythmia like ventricular tachycardia or ventricular fibrillation, which is why we're going to be wanting to have continuous ECG monitoring. There are a number of potential therapies that we can use to bust a clot or to repair a clot or an occlusion of some form. We can use thrombolysis to try to break up that clot as it is, which are going to be done through enzymatic enzymes. Percutaneous transluminal coronary angioplasty is a popular term or popular therapy that we can use to try to expand a balloon in that damaged tissue and make room for some blood to come through. A lot of times they're going to want to put in a stent over that newly ballooned area to help secure the clot that was there. And sometimes the clot's not going to be capable of being fixed in any other way, and so they have to do a coronary artery bypass grafting where they literally take a bit of vasculature from somewhere else and tie it around the clot. So in addition to everything else, we can also have a form of acute coronary syndrome called sudden cardiac death. Realistically, this is just a form of, this is like a specific type of death that results within 1 hour of symptom onset, and it is unexpected from cardiac causes. We can try to make this, to increase their chances of survival by providing external defibrillators and performing CPR, since generally sudden cardiac arrest comes from ventricular fibrillation. But of course, the survival rates for external defibrillation and CPR don't exactly have the best survival rates. The big thing to remember here is that this is unexpected, and that the death of someone who was experiencing, death occurs within 1 hour of symptom onset of any cardiac issues. And that's pretty much it. Let's see, I guess that's it. All right.